Welcome to impactID Clinical Insights. This discussion is about meeting the challenges in treating patients for which standard approaches are not adequate and is moderated by Dr. Daniel Kuritzkes. Our panel discussants are Dr. Paul Sachs, Dr. Joel Gallant, and Dr. Roy Gulick.
Hello and welcome to this discussion of rising to the challenges, which will cover some of the issues that we face as clinicians in dealing with patients who, for which standard approaches are really not adequate. I'm Daniel Kuritzkes. I'm professor of medicine at Harvard Medical School and chief of infectious diseases at Brigham and Women's Hospital in Boston, Massachusetts. And I'd like to welcome my distinguished fellow faculty members on this afternoon's panel. Although most HIV-infected patients treated today can achieve viral suppression and live healthy, normal lives on a range of available therapies that are recommended as the first-line regimens for patients, there are unique patients who, for a variety of reasons, face specific issues that don't permit us to use the standard regimens. And finding the right regimen for these patients can be a real challenge. Those challenges are going to be the focus of our discussion today. So let's start with an example or the first of these topics. And let me ask you, Joel, what are the key considerations in managing a patient with multiple comorbidities, let's say cardiovascular risk, renal disease, diabetes, maybe some hypertension, and the need to treat those conditions as well as provide antiretroviral therapy?
Yeah, it's a great question. Usually this affects the nucleoside component. We don't have so much trouble with the third agents because we have a lot of choices. But since our two nucleoside backbones are either tenofovir emtricitabine or abacavir lamivudine, we can sometimes run into problems where we don't want to use either one. With tenofovir, it's usually a renal issue. With abacavir, it's usually a concern about high cardiovascular risk with multiple cardiac risk factors, or sometimes a positive HLA-B5701 test. So when we feel we can't use either tenofovir or abacavir, we're a little bit stuck. The guidelines talk about so-called nucleoside-sparing regimens, but without really giving us direct guidance on what regimens to use, mainly because the ones that have been tested have been problematic for a variety of reasons, poorer efficacy at high viral loads, for example. And so we're sometimes stuck either with using one of the regimens that the guidelines discusses, but that have weaknesses, or coming up with one that has never been tested using extrapolation from existing data. And people will fall in various camps as to which of those approaches they'd prefer to use.
And although I'm sure most of our audience will be familiar, do you want to just remind us what the HLA-B5701 test is, why we do it, and whether you do that on all your patients routinely?
I have not. The test is to prevent abacavir hypersensitivity reaction, which doesn't occur when you are negative for HLA-B5701. It has a very high negative predictive value. But when you're positive, you're considered to be allergic to abacavir and are not supposed to use it. In the past, I have not been doing this as a routine test, although I'm starting to change my approach because the combination of abacavir, lamivudine, and dolutegravir is an attractive first-line regimen. So you could argue that maybe it is an appropriate test to use as a baseline test for that reason.
Well, I would say it still is being used by you for the same reason. You're considering using abacavir, and that would be how I would describe my use of the test. And yes, I'm increasingly doing that because of the combination of abacavir, lamivudine, dolutegravir. But I'm still doing it because I'm considering using abacavir. Otherwise, it really has no indication. I mean, there are some interesting associations between that exact allele and HIV control, but they're not really useful in clinical practice.
But when you first evaluate a patient, are you getting a B5701 because sometime in the future you might consider an abacavir regimen, or only when you're about to prescribe abacavir?
For me personally, it's the latter, and I just, for example, saw someone who's a guy referred from a local university. So he's a young guy, he's in his 20s, and he's an ideal candidate for a single pill regimen, and he has zero cardiovascular risk. And for him, getting this test made sense because then he can go on abacavir, lamivudine, dolutegravir. But I wouldn't be getting it on an older individual who has multiple cardiovascular risk factors because I would probably not want to use abacavir in that case.
It's interesting that it's one of the few genetic tests there's such a direct relationship between being positive for this one marker and having this very severe reaction, and that you can almost rule it out completely if the person's negative. There's not a lot of other tests like that in medicine that we actually use.
One of the challenges with using the single tablet regimens, particularly around renal function, is that when you get to a certain threshold of creatinine clearance, you either have to adjust the 3TC dose if you're giving 3TC, or you have to adjust the tenofovir dose. So how do you approach that, and when are you forced to split up the STRs, and are there alternatives that allow you to still give simple regimens?
I think we're all seeing more of this over time. Tenofovir toxicity is cumulative, so this issue does come up. I think it's tenofovir most commonly that we run into problems with. And as the creatinine clearance begins to approach 50 is when you begin to get concerned. And the package insert says it's time to think about doing every other day as one approach as people go 50 and below. But many of us would consider switching prior to getting to there. In my anecdotal experience, sometimes you'll switch to every other day and the person continues to progress and then develops proteinuria. And
yeah, I mean, one of the difficulties with the renal issues, and this is sort of kind of what all the nephrologists have been telling us for years, is it's not just one thing. And so as our patients get older, yes, they've been on tenofovir longer, but they're also getting older, and that means they've had more time for their comorbid conditions to start to take their toll on their kidney function. And in addition, they may have, just by getting older, when you calculate their estimated GFR, it automatically goes down. So it's going to continue to go down no matter what. And so yes, tenofovir was approved in 2001. A lot of our patients have been on it now for over a decade, and it's starting to be a little tricky to manage.
Yeah, and I particularly don't like using dose-reduced tenofovir in somebody who has tenofovir-based tubulopathy. I mean, if somebody's really got evidence that they're wasting phosphorus, that they've got proteinuria, or approaching a Fanconi's, even dose-reduced tenofovir doesn't make sense to me. Maybe if you've got renal dysfunction for some other reason, you might consider that. But usually you have some other options.
Exactly. The one group that I've done it in, and I don't know what your approach has been, is tenofovir really is our best hepatitis B drug. And I kind of have trouble taking people off of tenofovir who need tenofovir for hepatitis B control, and tenofovir isn't quite as good a drug, especially if they've had previous lamivudine exposure. So they're the only ones I can think of who I'm dose reducing.
so you're willing to risk it and go a little bit farther, but it is a cumulative toxicity, and it just keeps getting incorporated into the tubule, so probably we're going to lose.
But the good news, at least I hope it's good news, is that we're close enough now to the approval of TAF that in those patients with hepatitis B where you really don't want to stop the tenofovir, if you can just keep them going until TAF comes along, we hope that TAF will be better tolerated from a kidney standpoint.
How good's the data with hepatitis B and TAF? There's a little bit of data,
It's going to be
right?
presented this summer in Vancouver at the IS meeting, or the International AIDS Conference.
I guess we'll also have to see what the label indications are in terms of when TAF dosing needs adjustment as a function of renal function. But one of the other challenges around finding alternative drugs in patients who have impaired renal function is that renal impairment often goes along with other cardiovascular risk factors, and so the other nucleoside that we've been talking about that might be substituted, abacavir, has some issues around that. Trip, how do you parse that out?
Yeah, it's a real problem. So the abacavir data, as we've been discussing today, the DAD study came out and said if you had associated multiple cardiac risk factors with the presence of MI in people taking abacavir. And other studies tried to replicate that result, and about half of them could, and the other half couldn't. Some of the ones that couldn't include the AIDS Clinical Trials Group study and the Food and Drug Administration study. But as many people point out, they confined their look at the data to clinical trials, and perhaps people with severe cardiac risk factors weren't referred to the clinical trials. The most recent studies, the NA Accord, the North America Accord cohort study, which combines a bunch of cohorts together, and they essentially replicated the DAD results, that there is an association between taking abacavir and the risk of MI, particularly in people with multiple cardiac risk factors. So then the question comes up, well, if someone has renal dysfunction, they may well have coronary artery disease too. Do you really want to choose either of those nucleosides? And I think in some cases you don't. You want to go to other options. And what are they? It's what Joel started to talk about, I guess, nuke-sparing regimens. I think it's interesting that some of these now are finding their way into the guidelines, often with the caveat that we don't have a lot of data. The IAS USA now has a couple of nuke-sparing or nuke-light options, and the DHHS now lists them as well.
But it's interesting, they do, but they can only talk about the regimens that have been studied.
Sure.
And the regimens that have been studied have definite weaknesses. So the classic example would be boosted darunavir-raltegravir, which in 2 studies have been shown to perform poorly at high viral loads. And so I guess the question is, do you go with the studied regimen that has known weaknesses, or do you extrapolate and say, okay, I'll try darunavir-dolutegravir, never studied, and maybe throw in some lamivudine or some emtricitabine just in case there's a fundamental problem with a PI integrase approach? That's my own preference, is to try to improve on the flawed regimens that the guidelines mention. But
Right,
they can't say that because there's
you don't
no
want to
data.
use lopinavir-ritonavir, for instance.
But actually, a lot of times, we're not talking about initial therapy. We're talking about people who are already virologically suppressed. And there are studies that look at this, NRTI light approach. They are randomized clinical trials. There's one called SALT, which is atazanavir-ritonavir plus lamivudine compared to atazanavir-ritonavir plus 2 nukes, and it was fine. And the other one is OLE, which is lopinavir-ritonavir plus lamivudine versus plus 2 nukes, and that was fine. And now there are uncontrolled data on darunavir-ritonavir plus lamivudine from at least 2 centers, and that was presented in Glasgow this year. So I think that approach for patients who are already virologically suppressed has a lot of appeal to it. The one downside, of course, is that they all have ritonavir-boosted protease inhibitors, and those are not necessarily the most friendly either from a GI standpoint or from a lipid standpoint. And in addition, I should say that atazanavir-ritonavir is associated with more renal disease. So,
with the switch studies, we've switched to a lot of regimens in our field over the years. I mean, even people that switch to triple nukes seem to maintain their virologic suppression. You can get away with a lot of things switching.
There have been a few recent failures, interestingly. I think that one of the most interesting was atazanavir-ritonavir plus raltegravir. No, that one didn't work well at all. There were more virologic failures and virologic failures with resistance. Another one that didn't work well was raltegravir-maraviroc for whatever reason. So some of the switch studies have been bad. It doesn't seem to be the case with the boosted PI plus lamivudine so far.
We've talked a lot about cardiovascular disease, about renal insufficiency. What about advanced liver disease? You touched briefly on the issue of maintaining treatment in patients who have chronic hepatitis B virus infection, but are there drug adjustments that you make or regimens you tend to avoid or favor for patients with advanced liver dysfunction?
You certainly get into problem with both the non-nukes and the protease inhibitors, since they're all hepatically metabolized. So you have to dose adjust perhaps, or you can't use some of these drugs at all. The nucleosides you can usually get away with because they're all renally metabolized.
There is some cautionary language about abacavir.
That's
I don't
true.
really
But it was really based on pharmacokinetic studies. It wasn't based on any clinical outcomes, as far as I know.
Yeah.
Integrase inhibitors might be attractive, and they're all metabolized by glucuronidation, but I don't think there's much experience in that group.
And then before we leave the topic of comorbidities, at least for the moment, there's been lots of discussion, and as far as I can tell, no resolution about whether you adjust the regimen for somebody who has cognitive impairment that's thought to be HIV related. And Paul, what's your approach on this?
Yeah. Well, the first thing I would do is I would see if the patient's on an efavirenz-based regimen, because even though efavirenz has very good CNS penetration, interestingly, in some studies, it's been associated with impaired cognitive function. So, and the neurologists who specialize in this area also don't like efavirenz in this context. But assuming the person's not on efavirenz, it might make sense, and if we've done this, to do a CSF exam and send the sample for HIV RNA, because there are rare cases of a patient who has this so-called CNS escape, where they have viral replication in the central nervous system, even though in the blood you can't detect it. But it's important that people realize that that's unusual, even with all regimens. So these days, I don't think there's any strong data supporting the use of any one regimen over another for patients with cognitive impairment, provided the regimen doesn't have efavirenz in it.
Yeah, I agree. The fact that you can still publish a case report of CNS escape gives you some idea of how uncommon it is.
Everyone's seen it. Everyone's seen a case or two.
Yeah.
It's just not very common
And
at
it's
all.
the reason that you should do the LP, I
Right.
think, and measure viral load.
Right.
The neurologists, the HIV neurologists are really, there's multiple camps on this, and you know you're getting into trouble when there's camps. So strongly believing that different antiretrovirals with different penetrations that make a difference, others disregarding that, and protein binding gets into it. It's really not clear. I saw a report recently that just compared cognitive function in HIV-infected people, but then had an HIV-negative control of the same age and reported many of the same issues in HIV-negative people. So the testing is controversial, and I guess 10 years ago we were all worried that we're going to use these regimens and that everyone's going to break through with dementia because the penetration into the CSF or to brain tissue was not the same, and we were using the more convenient, better tolerated drugs, and were we going to pay the price? But we didn't.
So we've all had the experience of patients coming to us and saying, you know, my friend just told me about this regimen that they're on, or I just saw an advertisement on the bus or in the subway about this great new single tablet regimen, and I want to get off the drugs that I'm on. Why can't I go on to one of these regimens? Trip, are there reasons or circumstances in which you would say to a patient, gee, you know, I'm really sorry that in your situation this just isn't going to work, and how do you manage that with your patients?
Sure. It's, I think one pill a day really does have some magic among patients and providers in our field. And obviously we have 4 to choose from and several more in development. So it's changed our field a lot. Almost everyone can take one pill once a day. But there are patients that it may not be appropriate for. And the best example are people that have cycled through previous regimens and accumulated resistance. And many of our one pill once a days are either based on non-nucleosides or are based on integrase inhibitors. And so if the nukes aren't maximally potent in that one pill once a day regimen, then people with pre-existing resistance will break through. And so it's probably not a good choice for someone with documented resistance or a history suggesting resistance to nucleosides, or even the other classes.
So if someone's, say, been on an efavirenz-based regimen and failed, and they had developed 3TC or FTC resistance, and they're now suppressed on a boosted PI regimen, are they sort of locked into that forever, Joel? Or,
Right now, that would be my preference, to leave them alone on that regimen. I think we are going to, you know, there's some preliminary data suggesting that dolutegravir with nucleosides may be a good combination even when there's some resistance to the nucleosides. But the numbers are very small, and so I think that people are jumping on that maybe a little prematurely. I would rather
I'm one
wait
of
and
one of
see.
those who's jumping prematurely.
Okay,
yeah.
tell us about it.
I feel like you know, when you look at the effect of 184V on nucleoside activity, you have really certainly no effect on tenofovir activity. In fact, you might get a little extra. Plus, studies one study that Dan did and other studies show that lamivudine and M-tricytidine still have activity when there's 184V present. So if a patient just has 184V, based on those data from the sailing study, I'm very comfortable switching them to tenofovir FTC dolutegravir.
Wow, that surprises me. I mean, the data from the sailing study are single digits in some of the groups. In fact, in one group, there's one patient.
0 out of 32.
That's the total.
Yeah. And the data, you know, almost, well, suffice to say, this tenofovir FTC's activity in patients with 184V alone is excellent. We know this from EARNEST. We know this from second line.
We know this with protease inhibitor based. We don't know this with dolutegravir.
It's as good as an integrase inhibitor.
As good.
So I'm
Well, I mean, it's interesting though. I mean, I probably fall somewhere between the two of you.
And you're sitting
right
between us.
But
he's the resistance expert.
But
he'll chime in a minute.
You pointed out that you would be comfortable with it using tenofovir.
Yes.
So in other words, not a single tablet regimen.
Exactly. Yes, not a single tablet regimen, and not abacavir, because abacavir's the effect of 184V on abacavir activity is the opposite direction.
right, absolutely.
Yeah, so I mean, I feel like tenofovir FTC dolutegravir. In fact, well, I mean, to be anecdotal, I've done it several times already, and patients are thrilled. So.
Thrilling doesn't mean they're going to be virologically
They are
suppressed.
suppressed.
We've seen some intriguing data from studies done in lower and middle income countries with second-line regimens where, despite the presence of nucleoside resistance, nucleoside backbone together with boosted protease inhibitors, in that case boosted lopinavir, seem to do just as well as raltegravir with the boosted protease, and paradoxically better in the people with resistance who might have been more adherent to their therapy than in people with wild-type virus. And I think that result still puzzles a lot of us, but it does tend to argue that with the right combination, if you're reversing resistance to one of the nucleosides, you may not be as badly off as you would think just from the
But can you
that's with the
extrapolate
boosted
to,
PI, right?
to dolutegravir?
Well, you know,
That's
it's
the
a
big
sailing
question.
study, even though you're right, the numbers are relatively small. The sailing study was a randomized clinical trial.
Sure.
And a prospective study, and they did this analysis very, very well. And I asked them specifically about what were the regimens the patients were on who were successfully treated in the dolutegravir arm, and it was predominantly tenofovir FTC. Sometimes it was tenofovir FTC and a third drug, a third nucleoside, but it was tenofovir FTC, dolutegravir.
There were people on that study with no active nukes on dolutegravir who's still suppressed, but not too many of them.
Well, and Tripp will remember from the original indinavir studies, there were people who suppressed on indinavir monotherapy. So there are always some people who do well.
I'm sure that we have plenty of people on efavirenz-based regimens, rilpivirine-based regimens, who have a 184V that we're not aware of, and they're doing just fine.
Of course. It's
not that we would do it on purpose.
Right.
But
I mean, if you think back to ancient history, 364, ACG 364, patients had extensive nucleoside resistance, and more than half of them virologically suppressed, going on the efavirenz plus nucleoside arm. I mean, that wasn't the winner. The winner was efavirenz plus nalfinavir plus nucleosides, but still, the efavirenz arm did very well. So just because there is some nucleoside resistance doesn't mean patients are doomed to fail, especially in the switch category, because the switch patients are better. They're better pill takers.
So this discussion about resistance is a nice segue to another topic that I wanted to touch on, and that is with the increased use of integrase inhibitor based regimens as first line. What are the kinds of resistance concerns that are now emerging and that we're going to face? We've been used to dealing with the emergence of non-nucleoside RT inhibitor resistance and nucleoside resistance, but what are you seeing in your own patients who might have failed an integrase inhibitor-based regimen, and how do you approach that? So, Joel, why don't we?
I have to say, I have seen one case of failure with resistance since integrase inhibitors started, for naive patients. It was a patient that was taking elvitegravir and developed an elvitegravir-specific mutation. Other than that, I can't say that I've seen this happen very often, and so I don't think it's going to be common.
I mean, it might depend on the context of what your practice is. I mean, our practice, as you know, Dan, is a mixture of a primary care and a referral practice, and so patients are referred sometimes with integrase inhibitor resistance, and that's sort of the context we're seeing it. It's definitely happening more than it was. It's still infrequent. And if I were to sort of make one message very clear to HIV providers, it's that once their patient has documented integrase resistance, they should stop the integrase inhibitor immediately, because otherwise they're going to involve to get dolutegravir resistance, and that is almost impossible to manage.
I agree with that, but the other thing that's happening, of course, is we're switching from twice-a-day raltegravir and boosted elvitegravir right to dolutegravir because of the side effect profile, the potency, and this theoretical barrier to resistance that's high.
Yeah.
By switching, you mean patients who are currently suppressed doing well on these other regimens are moving over to dolutegravir-based regimens for the reasons you mentioned.
And as initial regimens.
Yeah, and as initial regimens.
Oh, I see. Okay.
But I think both things are going on, really. I mean, why would you use a twice-a-day integrase inhibitor today when you don't have to? And less common, I guess, is why would you use a boosted integrase inhibitor if you don't have to? Although that's sometimes the one pill once a day argument.
So when you have that rare patient who has failed on raltegravir or elvitegravir, and let's say they do have one or maybe two mutations that they've selected for the integrase inhibitor, what do you do next then? What's the next regimen? Can you go to dolutegravir? Do you use dolutegravir with the same nuke backbone, or do you have to modify the backbone?
Well, I think likely the patient failed because of non-adherence. And so to me, that person has graduated to the PI class until you figure out what's going on. So it would be rare that I would be comfortable simply switching from raltegravir to dolutegravir based on a resistance profile without thinking, why did this person fail such a simple regimen? So I would tend to move to a PI and then save dolutegravir for the future someday when I thought that adherence was better.
Well, and we do have clinical trials data looking at people who failed raltegravir or elvitegravir, and then beginning to understand the genotypes, the integrase inhibitor genotypes. And we know the substitution at 148 is the one associated with dolutegravir resistance. But if you don't have the 148, people do well, or generally well. The studies use double-dose dolutegravir, so that's important to remember. So it's 50 twice a day, which makes the regimen more complicated. Going back to Joel's point, if they failed because they were non-adherent to a once-a-day regimen, they certainly aren't going to do very well on a twice-a-day regimen.
One interesting thing about those studies, the Viking studies, is when you look at some of the patients, especially the ones with, I believe, 155H, their in vitro susceptibility to dolutegravir was still very good. I mean, they probably could be treated with once a day. I wouldn't do it because the package insert says twice a day. It's still not that common, but it sort of underscores the importance of getting people off failing integrase regimens if they have resistance sooner rather than later, because it's only after you get the 148 plus others that dolutegravir really doesn't work. So,
but I think this is going to be a temporary thing. I just feel like the whole field is moving towards dolutegravir, once a day, better tolerated.
One thing that would be nice from a practical standpoint is that most of us who are ordering genotypes are still getting genotypes that for historic reasons contain just RT and protease. And it would be nice if we could get all four drug classes, the NRTI, NNRTI, protease, and integrase in one test.
There is one available.
There is, but it's not, you have to pay a little
You just
price
got to pay
premium
for it. You can get all of this
You
stuff.
can get whatever you want.
Yeah, I know. It just seems that since integrase inhibitors are being used so much more widely than they used to, it's going to be the rare patient who you're not going to want to have that information.
I disagree. I mean, the guidelines don't recommend this right now.
No, I'm not talking about initial. I'm not talking about
you're talking about
on
subsequent.
I'm talking about, like, for example, recently in the hospital, this patient got admitted who, described his experience going down to the Dominican Republic and getting an illness, which probably was chikungunya, and he decided, I'm stopping my HIV medicines. This is, I don't know why he decided that, but that's why he just stopped then. So now he's sick in the hospital with not chikungunya anymore, but now with some HIV-related problem, because it was months ago. And he was taking before a dolutegravir-containing regimen. And as part of his evaluation, we of course want to assess whether he has any resistance. And integrase resistance is key.
Do integrase inhibitor mutations persist? This guy's been off for several months.
Well, that's a really interesting question. I don't think we have really good data on this because we don't have the kinds of treatment interruption studies. Most patients have ended up on some kind of a suppressive regimen or have transitioned from one integrase inhibitor to another, so we don't know as clearly as we did for some of the other drugs what happens. I think if we found people who had transmitted resistance who then didn't go on to therapy right away, we might be able to answer the question, but it's going to be hard. We know clearly that the mutations do produce a hit on viral fitness, and so logically you would think that over time those viruses would be replaced by wild type.
But I guess what Trip was implying is, should we still send an integrase genotype in someone like the patient I mentioned? I mean, he did stop an integrase-based regimen. Obviously, if you find an integrase mutation, it would be useful information.
Yeah, I would follow the same guideline that we
thought.
do for other drugs. If it's been within 4 to 16 weeks or something, that it makes sense to send. But the further out you are, the less reliable the
But if
result.
you get a positive result, obviously you believe it. If you get a
That
negative
you can
one,
take
then
to the
you don't
bank.
know if it's
Right.
been outgrown by wild type.
So one comorbidity that we didn't address, and that sort of crosses all three of these areas, and sometimes we may not think of it as so much as a comorbidity, but the patients who have significant psychiatric disease and significant substance use problems who are challenging to treat and who may have significant adherence challenges or whose lives are chaotic in a way that makes regular medical follow-up a challenge. How do you find a regimen for those patients that fits and is simple yet effective and without much risk of resistance. I've always found it a paradox that we use more complicated regimens because they might have less resistance concern.
Well, there are always two camps on that subject. There was the group that would say use the regimen that they can't screw up by not taking it, and that would be a boosted PI. The others would say that makes no sense at all. You want to use the simplest regimen possible, which would be single tablet. You know, the gaps between those two are narrowing. You can now give a boosted PI-based regimen with 2 pills a day, and it'll soon be 1 pill a day. At the same time, we have a single tablet regimen that may be pretty resistant to resistance, namely dolutegravir. So it's getting to where those are not such extremes anymore. And I'm still of the kind of the camp that I'd probably rather use a boosted PI, but I certainly understand the rationale for a dolutegravir-based regimen.
Yeah, I think a lot of people are moving. It used to be we would say use a boosted PI, but even the best ones may not be that well tolerated. And patients in this camp may often stop just with any kind of side effect at all. And that's why we do turn to integrase inhibitors in that group, just because they're so incredibly well tolerated.
Another factor is drug-drug interactions, which, you know, with a boosted PIs, by definition, have a lot of drug-drug interactions, and patients with psychiatric disease are often on many medications. They're tricky to manage.
You know, there's also the property of regimens that we used to call forgivability. If you dropped a dose here or there, if the drug had a long half-life, efavirenz being the one great example, that people would remain suppressed.
Yeah. In fact, you know, even though this patient population you don't want to use efavirenz in, efavirenz virologically really still has never been beaten by anything. It's the one thing we know is that as far as virologic suppression, patients with high baseline viral loads, the low CD4 cell counts, nothing's ever been better. And even the dolutegravir single study, it was only better because it was better tolerated. So, yeah.
So underlying most of the comorbidities that we discussed is inflammation. And we've talked a lot about how inflammation increases the risk of different end organ complications. How do you assess inflammation clinically, and what do you do about it? Trip?
You know, I think we're at the cutting edge of what we know right now. There's a huge research agenda to try to do this. You know, can we send lab tests telling us that our patients have inflammation? People sometimes use an ESR or a CRP, but there's nothing really in the clinic, I think, that we can do outside of a research setting to really assess inflammation right now. We know antiretrovirals are one of the best ways to decrease inflammation that's associated with HIV infection. Other things like stopping smoking. But no, I don't think there's routine lab tests that people send from the clinic to try to do.
Yeah, I completely agree. I mean, this is one of the areas where there's the biggest disconnect between the translational researchers right now and the clinicians. Because when the translational researchers get up and show all of the cytokines that they're measuring, their IL-6 and CD4 activation markers, and it really has no direct correlate in the clinic. You cannot measure those things in routine clinical practice. Yes, you can get a CRP, but what are you going to do with the information?
Right.
So it's really
how do you treat that?
It's D-dimer. I mean, those are the tests you can at least order. I mean, I suppose you could order an IL-6, the oncologists do, but in HIV clinic, it doesn't make any sense.
I mean,
yeah.
Where I practice, I get a lot of people who come to me they moved to Santa Fe, and they come with their records, and they got routine CRP, ESR, D-dimer, CD panels that took a whole page of CD things that I didn't know what they were. And in the end, what was the answer? Antiretroviral therapy. Yeah, you know, I mean, no matter what those studies showed. I mean, there could come a time when everybody's on a statin. And I think we may be moving to that point, but I'm not sure that even those inflammatory markers are going to tell you whether that's the right thing to do for that patient. It'd probably easier just to give everybody a statin.
Well, that's a testable question, isn't
yes,
it?
And it's
whether
being tested.
Whether we should give statins to everyone or not. You know, I saw a guy in consultation who was one of the folks who had excellent suppression but never had a CD4 increase. And I thought, well, can I assess inflammation here? Sent off CRP and ESR and D-dimer and got some results back. But again, I thought, okay, now what do I do? What can I do? He's maximally suppressed.
What about aspirin? Are you more likely to prescribe aspirin to your HIV-infected patients?
I tend to be more likely to prescribe a statin. And the reason I say that is because I think statins are, at the right doses and with the drug interaction considerations, relatively benign with possible great benefit. Whereas aspirin, you can do harm with aspirin. So I tend to follow routine guidelines with aspirin, but I'm a little more aggressive with statins than I might be in an HIV negative person.
So some of the cardiologists actually, question how useful aspirin is for primary prevention in the statin era. That it may not even.
That's interesting.
Yeah. So I mean, it's different once a person has had cardiovascular disease, but beforehand.
So I guess it depends if you want to trade the risk of a GI bleed versus the risk of myositis, right? And what about assessing the extent of cardiovascular disease? Do you do coronary CTs on patients, or are you guided by symptoms? How aggressive are you in the workup of patients for cardiovascular disease?
I'm guided by symptoms. I don't do anything as a screening tool, short of managing cholesterol and other risk factors.
Yeah, I suppose I would say there are really two schools of thought on this issue. I mean, there's the one school, which is backed by some data, which really is espoused by Steve Grinspoon and his group, which is that this is really a very common problem in the HIV population overall. And then there's another school, which is much quieter, like, for example, the group out in Kaiser, who say, look, if you take your patients and they're really well treated and they're not smoking and they don't have a lot of other cardiovascular comorbidities, they seem to have the same cardiovascular risk as HIV negative patients. And it may not be 100% of the HIV group that's HIV population that's at risk. And there was recently another, I think a Swiss study that showed kind of the same thing, or from somewhere in Northern Europe, that if you take away the comorbidities that go along with having acquired HIV, which may be risk-taking and therefore smoking is one of them, then you may not see as much.
So that's the risk factor associated interventions, I think, are the right way to go. I mean, the traditional ones. So you can't change your family history, we all know that, but cigarette smoking, much more common in HIV-infected people, and you can do something there. Lipids, as you mentioned, et cetera, hypertension, you treat.
So are there particular approaches to cigarette smoking cessation that you found successful?
Wow, it's tough, but I think different things work for different people, and so some people do well with patches, some with gum, some with intensive case management. So kind of going through all of those things and offering people different choices. Some people cycle through everything and it doesn't work. I think people are just tired of me talking about it, and so they tell me they stop.
We heard a fascinating statistic recently at a conference we were at, where the proportion of people with HIV who smoke cigarettes is around the same as the proportion of Americans who smoked in the mid-1960s. So it's about 40% or so. Yeah. So, it is a problem. And one of the pushbacks we sometimes get from our patients is they'll say, I've given up everything. I've given up drugs. I've given up sex. You want me to give this up too? Exactly.
What's worked right here in New York is simply raising the prices, which is not something we would do. But I think in New York, only 20% or less than 20% of adults smoke. It's really low compared to the national average.
Raising the price has definitely decreased smoking in the United States overall, without a doubt.
And what about lipodystrophy and fat accumulation? And is that still a problem? And how do you handle that?
I would just say that no, it's not a problem. I think the data we saw from the sub-study of 5257 showing...
That's the ACTG study that compared boosted
raltegravir boosted atazanavir boosted darunavir. And I guess there were people who still thought that PIs caused fat accumulation because everybody seemed surprised that there was no difference in the fat changes among the regimens. And what I think we were seeing is that as people get healthier, they gain fat. I don't think we were seeing abnormal lipoaccumulation. I think we were just seeing that people, when their viral load goes from some high number down to undetectable, they gain weight, and some of that's going to be fat, some of it's going to be lean body mass.
Return to health.
So it's a return to health phenomenon. The fact that there was more of that in people with higher baseline viral loads suggested it was a bigger return to health, and therefore they had more fat changes.
Yeah, I agree with you. It's not the drugs themselves, it's the treating the HIV, but it does cause problems in our patients. This almost inevitable weight gain that they have when they go on therapy. And so all of us have in our practices people with disfiguring amounts of weight gain that they will ascribe to their HIV medications. And even though it's not specifically the drugs that are doing it, it's the treated HIV, they're really becoming like the general population and gaining weight quickly.
And as I say, this is the weight you would have been if you hadn't had HIV. It's subcutaneous fat. It's not visceral fat.
It's a little different because it's faster. The weight gain is faster, and it's happening at older age. So the risk factors for large amounts of fat accumulation in HIV are people with advanced disease who start treatment and people who are older, and so it bothers them a lot.
In Grace McCumsey's analysis, wasn't some of the fat gain that she was cataloging visceral adiposity?
Well, it is, but the question is that different than what you would see with any disease where you return them to health? Some fat is going to be visceral, but what we weren't seeing is the distended bellies and the buffalo humps and the fat deposits, and we were just seeing an overall increase in fat.
So there's now treatment for fat accumulation in HIV. Have any of you had occasion to use that?
We've studied it, but it's only as good as how long you continue it, and it's got side effects.
So this is the drug tesamorelin, right?
Yeah, and very expensive. It's hard to get it approved.
So it has been very effective in some of the patients, and so I still have some patients on it. It has been not effective at all in others, so there seems to be some dichotomous distribution in response to the drug, and the patients basically can tell you, I know this has made a real big difference for me, or it's not doing anything. As Tripp said, there are some side effects, and so the one that is most concerning is when people's glucose starts going up, and it is very expensive. So it's not that I have a lot of patients on it, but I certainly have treated some people, and they have been people with massive central fat accumulation. Otherwise, they wouldn't have been able to get it.
I think that the argument I've heard that makes the most sense for use of this drug is in the person who really intends to start a very aggressive lifestyle modification, but diet and exercise, and needs something to kind of help jumpstart it, because he's going to have to maintain that kind of lifestyle modification program after he stops this drug, and without that, it's all going to come back.
Yeah.
And diet and exercise actually works too.
It works, but it's very hard for people to.
Well, it is hard, but it's hard for the general population as well. It's hard to stop smoking. It's hard to diet and exercise.
It is important that we get the message out, though, that it's not specific antiviral agents that are doing it, because the patients often say to us, it's these pills. Switch me to something that won't cause this weight gain, and that's not a switch that's going to be successful.
I guess another good news item is that lipoatrophy seems to be gone now too. We don't see loss of facial fat anymore with the drugs that we're using, and that was such a distinguishing and disfiguring thing for patients, feeling well and then having just this really gaunt appearance.
So has that robbed a lot of the urgency around the nuke-free regimen agenda?
Yeah, I think so. No nukes was a big catchphrase not too long ago, and then people got more comfortable that we weren't seeing terrible lipoatrophy when we stopped using the D4T, AZT, et cetera.
I mean, it's pushed us. As we started the discussion talking about kidneys and heart disease, and that's what's pushing the nucleoside limiting approaches now more than lipoatrophy. So.
Maybe we could spend just a couple of minutes about the use of some of these drugs in prevention and the issues around toxicity in that setting. Tenofovir and FDC are approved for prevention of HIV transmission, but obviously still concerns about longer-term toxicities. How do you approach that, Tripp?
Yeah, I think the first thing to say is if you're using a drug to treat, you're going to tolerate some degree of toxicity if it works. If you're using a drug to prevent, you can tolerate almost no toxicity at all. And that's really important, just when we think about global populations. So something you're going to dish out to people to help them prevent something has just got to be extremely well tolerated. So the only drugs, as we know, that are approved for HIV prevention are tenofovir, FTC. It's been looked at quite carefully. The renal was uncommon really uncommon in the HIV prevention trials of HIV-negative people who took it. And the bone changes were relatively uncommon and completely reversible when you stop the drugs. But it would be nice to have agents where you don't have to worry at all about
Ideally,
toxicity.
you'd want to use TAF and FTC, but I don't know what the pathway to approval for that as prevention would be, since you'd have to presumably replicate the large trials.
But wouldn't a regularly powered clinical trial versus TDF FTC?
Yes, but a regularly powered prevention trial is
it's got to be much bigger, of course.
5,000 or
Yeah.
bigger.
Unfortunately, I think we've run out of time. This has been an amazing discussion. I think we've covered lots of ground, and just to quickly summarize, I think it's clear that with the increasing complexity of our patients as they age, we're facing the challenge of managing more and more comorbidities along with antiretroviral therapy, and sometimes finding the right regimen for patients is a challenge, but there are enough options that we can find regimens for virtually all of our patients, but there's no clear algorithm for doing so. Everything has to be individualized. That we don't really have good clinically useful markers of inflammation that are appropriate for use in the clinic on which we would act today. Integrase inhibitors are becoming more and more commonly used. We're not seeing a lot of resistance yet, and exactly how to manage second and later lines of therapy in patients who start with integrase inhibitors is something that we're going to learn. And we'll look for the outcomes of a lot of ongoing work to see how we can move things forward and where the field takes us next. So thank you all for a very stimulating discussion. It's been a pleasure.
Thank you, Dan.